Going to continue our discussion on spinal cord injuries, having previously covered patient assessment, at least in the primary, basic assessment principles, anatomy and physiology, and mechanisms of injury. Now we're ready to move on to the spinal cord injuries themselves. In this lesson, we're going to talk about a couple specific spinal cord injuries. So I've got two slides that list them. So we've got cord concussions, cord contusions, and cord compressions. Now, the terms here are going to be similar to some of the terms that we've discussed in traumatic brain injuries. Like a concussion generally results in some injury and can have some microscopic bleeding at the level of tissue, but generally resolves itself and does not, if by itself, often produce long-lasting injuries. In some cases, multiple concussions or severe concussions can, but usually do not present long-lasting injuries. Cord contusions will have a little bit more of a breaking of blood vessels and accumulation of blood in the process. Cord compression is a little different than traumatic brain injuries we've talked about before, in which the cord itself has pressure on it externally that's now restricting the flow of cerebral spinal fluid and the conduction of nerve impulses through that process, as well as blood flow. Cord laceration would be a cutting of the cord. Spinal shock and neurogenic shocks are two different results of spinal cord injuries that we'll discuss and can be life-threatening. We'll also talk about complete cord transection and incomplete cord transection. Incomplete cord transection means that the cord has not been completely cut from below and above the injury. There's a partial cut, and that partial cut can come in a combination of patterns. And so we'll talk about injuries where the anterior portion of the cord has been impacted, the central portion of the cord has been impacted, Brown-Séquard, and a few other injury patterns as well. All right, so let's dive in. Generally, cord concussions are going to have a slight or temporary disruption of cord function distal to the injury. And so this would mean that depending on what portion of the cord and where it's impacted, distal to the injury, we may have a combination of or isolated presentation of lack of sensation or lack or lack of motor skills, but generally is temporary in the same way that a traumatic brain injuries version of concussion is usually temporary. Cord contusions are a little bit more, are a higher degree, rather, of injuries in which now we have disruption of blood flow, likely blood vessels have been burst or impacted by the traumatic injury. And so the bleeding that occurs can disrupt the cord function distal to the injury in the same way. It could be a combination, depends on where it's at, but this can result in permanent cord injury, whereas cord concussion generally will be temporary. Cord compression occurs, as mentioned before, when there's some type of pressure being put on the cord. And the spinal cord is made up of neurons and axons transmitting nerve impulses up and down the spine, ascending and descending. And so any impact or pressure on the cord is likely going to result in dysfunction of the cord from the point of injury. Now, this can come from things like bone fragments putting pressure on the cord when the vertebrae have been fractured. The discs sliding and pulling the cord with us. Remember, our disc has the cord in the center, so if the disc slides, it pulls the cord away from midline, and the cord generally doesn't stretch very well. So even a little bit of disc movement, if it doesn't move the cord, can put pressure on one side or portion of the cord as well. Hematomas or accumulation of blood can occur, which will put pressure on the cord. And then edema of the cord itself or edema of surrounding tissue can put pressure on the cord as a result of injury. And often edema in the spinal cord will present a long-lasting injury or impact for dysfunction in these patients. This can often result in permanent loss of function as a result of the cord compression. Cord laceration results in a tear or a cut of the spinal cord tissue itself, and this may come from or be in combination with other types of injuries as well. Now, if we have a cord laceration, we are disconnecting some portion of the spinal cord from the rest of the body. And so the distal cord may no longer connect to the proximal cord, or a portion of the cord may not connect. And this generally results in irreversible neurologic injury. Although there's a lot of advance being made in science today and medicine, we still haven't solved the issue of connecting somebody's spinal cord or allowing that tissue to heal in a way that returns function after somebody has a laceration or cord transection. Cord transections now are where the spinal cord at the point of injury has been severed, you could think of, severed from the communication above and below that point of injury. So when we have complete cord transection, the result of that is that there's no communication whatsoever, and this is irreversible. Now, the result of impact on the patient, right? Will they be able to move their arms and not their legs? Will they be a quadriplegic? Will they not be able to breathe? Will they lose function of their bowels? All of those things are dependent on where the spinal cord has been transected along the spinal column and the nerves that branch off of that region or the region below the injury of the spinal column. Now in this picture, we're going to show a picture that's similar to this in the next few slides. This picture is showing the spinal cord, anterior and posterior. And in the presentation of the spinal cord, we see that all of it is grayed out. So that means that the whole cord has been transected. So at this point, all nerve fibers from above the injury are no longer communicating below the injury. And if we assume that the injury was along the lines of somewhere within, say, T3 or 4, the patient will lose sensation and motor function all the way down from that point of injury. And that's what this dark shading is to represent. So spinal function at and below the level is lost permanently, not reversible, and where it is will depend on what vital signs and what impact it has on the person. But when this occurs, also remember it's not just the ability to move or sense, move their legs and arms. It's also going to impact the ability of their blood vessels to vasoconstrict and maintain circulation. Our body's movement in lower extremities is what helps get blood back to our heart, so they'll lose some of that. So it can have an impact on other systems, not just the spinal cord and skeletal and sensation. All right, now where the injury is has a big impact on this patient's condition, life, and how hard we're going to have to work to keep this patient alive. Now, if somebody has a complete cord transection, where their transection occurs is what dictates most of this, as back to our first few slides where we described the severity of injury is dependent on the amount of the cord damaged and where that injury occurred. At the EMT basic level, you may have heard a rhyme or a song that helps you remember where spinal cord injuries are in the cervical spine and how that relates to whether the person will lose the ability to use their extremities and stop breathing, or if they'll be breathing and lose the use of their extremities. So generally, if the person has a complete cord transection that occurs anywhere in the cervical spine, it will result in quadriplegia. And this is mostly because all of the branching of communication for the extremities occurs below the level of the cervical spine. However, there are branches off of our spinal cord that create spinal nerves branching off and communicating with the rest of the body that start at the very base of the skull. So even if we have injuries above the level, of their being able to control their arms and legs, they may have also impacted their ability to keep their vital signs, keep themselves alive. So the saying was essentially, if you have an injury between C3, 4, and 5, it's going to impact the patient's ability to stay alive. Okay, or said a different way, another learning tool or rhyme might have been C1 through 4, breathe no more. So the idea here is that because of the branching of a specific set of spinal nerves, the phrenic nerve as part of the cervical plexus, reminder, cervical plexus or a plexi. A plexus is a combination or collection of spinal nerves that are branching off of the vertebrae and then communicating with a region of the body. And so in this connection, the cervical plexus branches off above C6, so C3, 4, and 5 is where the branching of cervical plexus occurs, and it includes the phrenic nerve. The phrenic nerve is responsible for managing the movement of the diaphragm, and the cervical plexus has a role in managing the movement of intercostal muscles. So if a person has an injury above level C5, then it's likely they have cut off communication with the phrenic nerve and cervical plexus, and the result will be the patient will stop breathing. Now, this is a concern because this will happen as soon as the cord transects. So if this is before we arrive on scene, the patient may be in respiratory and following cardiac arrest very quickly after the incident has occurred. In some cases, the person had this occur immediately upon impact and resulted in traumatic arrest and probably death that was not reversible. Now, if the person has an injury of the cervical spine, but it's below the level of C5 and C6, they'll be able to breathe, but they'll still be essentially a quadriplegic. Because of the injury being below, if they're at C6 and 7, they're below the level of the cervical plexus, so that's still communicating with the chest, the diaphragm, and allowing the person to breathe, but they will have lost a sensation and movement of their extremities. If the person has a transection lower between T1 and L1, this may result in paraplegia, in which the person's lower extremities no longer are moving, but their upper extremities may still have sensation and they will be breathing, assuming that it's an isolated injury. When we describe terms like para and quadriplegia, this describes how many of their extremities they're able to sense and move. And they can occur in different degrees of severity, where maybe there's partial sensation or partial movement, or absolutely none. And this is, again, dependent on where the injury is in relation to the branching of those spinal nerves. For example, injuries that occur between T4 and T12, where we have a cord transection, may still allow some hand movement to occur, but an injury at T1 may not, because at the level of T1, we're still branching to communicate with all regions of our hand. But if we are between T1 and T4, or rather that's where the communication is, if we're below T4, some function in the hand may still be present, but likely not all of the arms, sensation, and movement present. So don't expect necessarily that you're going to find the person is fully paralyzed as a result of these cord injuries. Or said a different way, if they have partial paralysis, they could have still a complete cord transection that just occurred in an unusual area that allows some communication to regions of the body and not to others. This diagram helps us kind of describe where these injuries occur. So as we're counting vertebrae, as a reminder, we start at C1 up here. We go down to the big spinous process at the shoulder blade, which is at C7. When we get below C7, the next vertebrae is T1, and we go down, counting T1, moving down the spine, counting up. So we start at T1, the next would be T2, T3, all the way down to T12, and then L1 starts down to L5. So that's the count of vertebrae. So when you're feeling on your patient on the back and assessing their spine, you're palpating every one of these vertebral processes. Start at C7 so you get your bearings, because you can't feel generally at all C1 through C3. Start at C7, count up. The next one up would be C6. Count verbally so you know exactly where these injuries are. Then once you've palpated as high in the cervical spine as you can, move back down from T1. The next one will be T2. The next spinous process will be T3, and continue down to T12. Just below T12 will be L1. That way you can pinpoint if there are step-offs or fractures or abnormalities, or even a clear line of demarcation where we've lost sensation that would associate with a specific vertebrae and a specific nerve. So if you can chart that the patient has an injury to T3, you'll partly learn from our discussion here what type of signs and symptoms that may result in for your pertinent positives and negatives, but also can specifically tell the hospital where the injury was, given that they may be backboarded and they don't want to unbackboard them, so they can do this assessment if they can rely on your precise assessment in doing so. So if the injury is in the area of C1 to C5, they will be a quadriplegic and probably apneic and in respiratory arrest because the diaphragm will be paralyzed. In the region of C6 and C7, the patient would likely still be able to control their breathing and not be in respiratory arrest if this is an isolated injury, but they will likely lose function and sensation of their lower extremity, their upper and lower extremities, and the rest of their body. If the injury is between T1 and L1, that can result in degrees of paraplegia and may not be full loss of function, could be variations of combinations of loss of function, or some regions of an extremity that still have sensation or function. Now, it doesn't always occur that when the cord is injured, we get a complete cord transection. In fact, incomplete cord transections occur frequently. And these have their own dangers, I think, for us associated with them. Now, when patients have an incomplete cord transection, if they move the wrong way, they may complete the cord transection, or if we move them inappropriately, they may complete their cord transection in our presence or end with our help in some degree. So it's very important with cord transections, incomplete cord transections, or these mechanisms that would lead to such, that we're careful and we use spinal motor restrictions appropriately when we need to, and follow your local protocol to achieve this. Now, when this occurs, depending on what portion of the spinal cord is transected, we may have preserved some function of sensory, we may have preserved some function of motor, or a combination of some of these in different regions of the body based on the portions of the spinal cord that were impacted. All right, so let's now take a look at some of the specific incomplete cord transection injuries that occur. They have particular names, signs, and symptoms, and are certainly all testable within our scope of learning at the paramedic level for trauma. All right, now let's look at the structure, or the anatomy rather, of the spinal cord. Just as a reminder, we covered this previously, but as we're going to go through the next slides, we're going to need to be able to say the anterior or ventral portion of the spinal cord does X, so that if there's an injury to the anterior portion of the spinal cord, we know what the result will be. We have an anticipation of what the signs and symptoms will be. So some orientations here for us. So when we're looking at this picture, although we have anterior and posterior marked, the spinal cord doesn't actually use those terms. Instead, we're going to be using terms ventral for anterior, so ventral, and dorsal. And dorsal means posterior, like the dorsal fin of a dolphin is on the dolphin's back, so dorsal is posterior. Those are the terms that we generally will have specifically for spinal cord anatomy. Now the picture here also has a highlight with a color key. So not in the color key, but just to highlight very quickly, is in the center of the cord is gray matter, which generally is made up of the cell bodies or other structures of the neuron, including some axons that don't have myelinated sheaths on them. The white matter, or the rest of the spinal cord around the central structure of gray matter, the white matter, just like we saw in the brain structure, is made up of myelinated sheaths around axons. So by and large, these are axons communicating both up and down the spinal cord, surrounding the central portion of the cord, which is made up of the gray matter. Now the colors here show that we have blue highlighting ascending pathways and red highlighting descending pathways. So the ascending and descending pathways describe which way the neural impulse is going to travel. So if we have an ascending pathway, that's moving up towards the brain, and ascending is usually sensory because it's traveling to the brain. Motor is traveling down away from the brain, descending pathways are traveling down away from the brain, and they are motor pathways. So you can anticipate that a patient that has an injury to the anterior or ventral portion of the spine has a higher likelihood that they'll have an impact to their motor control more than their sensory. But as you can see, we've got a descending pathway right next to an ascending pathway as well along the lateral portions of the spinal cord. Now, the dorsal horns of the spinal cord are made up of interneurons. The ventral horns generally are cell bodies of somatic motor neurons, so they're going to impact skeletal muscle through the ventral roots. And these are the pieces that are branching off of the spinal cord, going in between the vertebrae and communicating with the spinal nerves transmitting through the rest of the body. The lateral horns also consist of sympathetic nerve bodies that are controlling the sympathetic nervous system and impacting visceral organs along, again, the ventral roots. So the motor control, or the descending pathways, are not just about physical movement, they're also about managing vital signs as well. The sensory neurons are going to communicate generally along the posterior portion or the dorsal side of the spine, and they're going to be communicating through the dorsal root ganglion. So this will be receiving information from the body, going through the neuron or the neurons of the spinal nerve, then communicating through the ganglion, which is a connection of these neurons, now transmitting into the spinal cord, and then likely this is a sensory pathway going back up towards the brain. Now, the structures of the dorsal root ganglion are generally communicating with the efferent nerves through interneurons that are in this dorsal horn as we described, and they'll communicate with white matter up and down the spine back to the brain. Okay, so though this is very complex, we can generally say that, yes, we have a mix of motor and sensory neurons throughout, but to generalize, most of the sensory neurons are in the posterior and outer lateral portion of the spine. The motor neurons are a little closer to the inside on the lateral portion and found on the anterior or ventral portion of the spinal cord. So that's to say that if a patient has an injury, say, to the posterior portion or the dorsal portion of the spinal cord, that would likely impact mostly our communication with sensory neurons. And it gets even more complex than this as we have different nerves branching off through the rest of the body. Okay, so again, to kind of describe some of these pathways, if we have impulses that are going through the ascending nerve tracts, they're generally sending nerve impulses up and to the brain, ascending. So those will include things like all of our sensory, like pain and temperature, touch and pressure, and then those combinations of motion, vibration, position, and light touch. Now, there is a crossover phenomenon that occurs within the spinal cord, and it really does impact specifically when we're talking about crossover for ascending tracts. Crossover generally is going to impact primarily pain and temperature neurons traveling across the spinal cord. Descending nerve tracts are essentially the opposite. Descending nerve tracts are going from the brain to the rest of the body. So they're going to be considered motor impulses, and they're going to control not just all muscle movement and tone, but they're also going to control things, as we mentioned, like the sympathetic nervous system, which is responsible for vital signs. Now, the descending crossover phenomenon occurs with motor neurons in the brainstem. So if we have an injury to the lower region of the body, the injury would be on certainly one side if we're describing hemispherical. And as it communicates up that one side, the crossover to the brainstem means that the other side of the brain is perceiving that, which you're probably well aware of, but you weren't necessarily perhaps aware that that crossover occurs right essentially at the top of the spinal cord or in the brainstem. Okay, let's go through some of these injuries. All right, so with anterior cord syndrome in our picture, we're showing that the anterior portion of the spinal cord has been impacted, right? So if the anterior portion of the spinal cord has been impacted, the mechanisms that generally produce this include bony fragments or pressure on the arteries that are feeding the blood supply to these neurons. Now, because of the impact location, so the anterior portion of the spinal cord has been impacted, the patient is generally going to lose a combination of things, but primarily they're going to have paralysis below the level of insult because of the function of motor neurons. Now, there are some combinations, though, again, because it's not all motor neurons in the front and sensory neurons in the posterior. We might have a loss of motor function and plus a loss, or we should say maybe a loss of pain, temp, and light touch below the point of injury as well. Some motor still could be present depending on where the injury is, but position and vibration sensations might also somewhat be present and not fully separated. So in this picture, we're showing the injury point in pink, and then you can see if the injury was right here, we would lose these sensations highlighted in pink in the body below the level of injury at that point. Central cord syndrome occurs when the area of damage is specifically in the center of the cord, and this usually occurs with injuries like hyperextension of the cervical spine. Central cord injuries then are impacting primarily the gray matter area of damage, and then collections of some of the anterior cord structures. And as a result, we'll have a loss of function in the upper extremities because some of the motor tracts and some of the sensory tracts are still present. So if the injury was found to be at this point, and again, the injury is in the center of the cord, it's highlighted by the picture, the patient may have a loss of motor function in their upper chest, so above the level generally of the nipple line, and then down both extremities, and this would be around the body. But they lose function there, but they have an incomplete loss of motor function just below. So between, in this picture, the pelvis and the point of the nipple line where they had lost motor function above. So we get a combination again of weakness and paralysis. So weakness meaning not fully paralyzed in upper extremities. The lower extremities are probably normal in finding. They may have good push strength and sensation when assessed. Now, in addition though, because the abdomen can have incomplete loss of motor function, this can result in things also including the loss of bladder function. So the patient may be incontinent to urine. And the presentation that is described here has kind of a layman's term associated with it that is described as the showl presentation, like putting a shawl over your shoulders, a piece of cloth over your shoulders that doesn't fully cover you. When the areas that are impacted with loss of motor function will have flaccid weakness of the impacted region. In posterior cord injuries, although I must have forgotten to put a picture here for us, but in posterior injuries and posterior cord syndrome, the patient has lost communication with the posterior portion of the spinal cord, which, just draw my spinal cord here. The posterior portion has primarily ascending pathways, right? Ascending tracks. So because of that, when the patient has an injury to the spinal cord that's primarily impacted the dorsal portion of the spinal cord, the result will be impacted decreased sensation of light pressure and touch, proprioception, and vibration. Proprioception is a term that you may not have heard a lot before, but essentially proprioception is the description of how the body knows where it is in space. So it's kind of relationship to other objects and understanding where it is within an environment. Quad equina syndrome is another type of spinal cord injury in which there's a compression of a bundle of nerve roots. And generally, if we're describing quad equina, this will be at the very low portion of the spinal cord where it terminates. And if you're looking at an anatomical representation, you see this terminus having a bunch of extension, which, as the name describes, looks like horsehair, quad equina. So this will be a compression of bundle of nerve roots that are in the lower region of the spinal cord, and can produce, as a result of the injury, compression that's impacting and causing low back pain, myalgia, which is the term for muscle pain, paresthesia, which is pins and needles that are sensed, or that burning sensation that you get when you're really cold and your hands start to warm up. So pins and needles are burning sensations, so not completely numb. And then myasthenia. And myasthenia is essentially abnormal muscle weakness. They may also have a loss of sensation to the areas that those nerves would communicate with. So that would be the lower extremities, the genitals, and between the legs. And they can have incontinence as a result. These will generally be injuries to the very lower portion of their back or pelvis. Brown-Séquard syndrome is a additional type of spinal cord injury. And instead of describing anterior, posterior, or central cord, as we have up to this point, this describes an injury to one side of the cord or the other. And I do have a diagram I'll show in a few slides, but first let's kind of describe this. So Brown-Séquard syndrome is going to be the functional hemisection of the cord, so one side versus the other, and can cause complete damage to the spinal tracts involved on that side. And remember, if we're talking about one side, that will have with it both our descending and ascending, or to say it will impact sensory and it will impact motor function as a result. Now, this brings up a good opportunity to talk about a term called spinal shock. And I want to caution you, spinal shock, which we'll describe a little bit more later, spinal shock is not the same as neurogenic shock, not the type of shock that you learned about at EMT Basic when somebody has a spinal cord that's been cut and their blood vessels below that point of injury open wide up and become a victim of distributive shock. Instead, think of spinal shock, or the term shock here, to be more along the lines of like a layman may be using the term shock. Generally, what happens in spinal shock is the temporary local neurologic loss that occurs immediately after spinal trauma. And in this case, the temporary portion of this could happen that it lasts long enough, up to 24 hours, before the signs resolve. So in our care, we may not be able to tell the difference between spinal shock and neurogenic shock because they may present similarly, although spinal shock proper would be temporary. And again, for us though, we won't be with the patient necessarily long enough to tell the difference, so we're probably managing the worst case scenario, which would be neurogenic shock. And neurogenic shock is not temporary. All right, let's continue describing Brown-Séquard syndrome. So Brown-Séquard syndrome is the results often of penetrating trauma that has transected one side or one half of the spinal cord. And because of the crossover anatomy of specific nerve tracts, we get a combination of signs and symptoms, remembering that our motor function, our motor tracts cross over in the brainstem well above most of the points of injury for Brown-Séquard syndrome. So this picture highlights the injury that can occur. So in this picture, the patient has an injury to their right side, right? The right side is damaged. So when this occurs, because of the crossover phenomenon, on the same side, they'll have a complete loss of motor function, proprioception. Again, that was the ability for the body to sense where like your extremity is in relation to the rest of your body, deep touch, and vibration. So that would be on the same side. In this case, it would be on the patient's right side. On the opposite side, they'll have a loss of pain, temperature, and light touch, but they will still maintain motor control. And again, this is going to be a hemitransection, so one side versus the other. All right, that wraps up the majority of our primary and secondary types of cord injury, and included a discussion on complete and partial cord transection and the different types of signs and symptoms that result from them. Now, again, this was kind of a difficult section, so if you'll allow me, let me just quickly go back, and we're going to cover these partial cord syndromes to describe their signs and symptoms without all of the description of the injury, just so we can cover the bullet points for these injuries. In anterior cord syndrome, the patient is suffering an injury to the ventral region of their spinal cord, and the ventral region of the spinal cord has a combination of ascending and descending tracts, but because it's mostly motor tracts that are impacted, the patient will have a loss of motor function, but still the preservation of some of the sensory function as well, below the level of injury. In central cord syndrome, the patient has, and this results often from hyperextension injuries to the cervical spine, where the center of the cord has been stretched too much from that movement. In this case, the gray matter at the center of the cord and some portion of other tracts around the center of the cord will be impacted. So usually this results in a loss of function, a kind of unusual pattern, where the loss of motor function is in the upper extremities, extending down the arms if this is a high injury. But the point below the level of about the nipple line down to the pelvis has an incomplete loss of motor function. As a result, though, they can have a loss of bladder function, and the description of the injury is a showl-like pattern. Posterior cord syndrome is associated with an injury to the what we call the dorsal region, or the posterior region of the actual spinal cord itself. Most of the tracts in that region are ascending tracts, so we're presented with a set of injuries that likely has a loss of light touch, proprioception, or knowing where your extremities are in relation to your body, or your body in relation to other objects, and vibration because of the ascending or sensory nature of the dorsal tracts. Quada equina syndrome occurs in the lower portion of the spine when an injury has impacted the low lumbar. As a result of this is where the quada equina, or the terminal end of the spinal cord, turns into all the spinal nerves that transmit down the lower extremities and into the pelvis and low abdomen. As a result, the patient will likely have low back pain, myalgia, paresthesia, and myasthenia, so that would be muscle pain, pins and needles for paresthesia, or burning, just like you have when your hands are really cold and you get some of that warmth returned to them, or blood flow returns to your hands, you get that pins and needles, or myasthenia, which is incomplete loss of motor function, loss of sensation of the genitals or between the legs because of the communication of those sensory tracts, and then the patient may have acute incontinence. And Brown-Séquard syndrome, which is the result of a hemisection in which one side of the cord has been impacted, often the result of penetrating trauma. Brown-Séquard syndrome, because of the crossover phenomenon, is going to produce different signs and symptoms on the same side as the opposite side of the injury. In our picture here, the patient has an injury to the right side of the spinal cord. The same side of their injury, because of the crossover phenomenon, will have a complete loss of motor function, proprioception, and deep touch and vibration. Now, part of this is because the crossover that occurs with our descending motor tract, so the motor neurons, crosses over in the brainstem, so it will impact the same side of motor control as the injury, but sensation does not cross over in the same way. It will be on the opposite side. So they lose sensation on the opposite side, and they lose motor function on the same side because of crossover phenomenon. And we did also mention spinal shock in the process. All right, the next portion of our lecture, I'll actually stop and restart again so you can take a stretch break. But the next portion of our lecture will talk about managing shock in spinal cord injuries. All right, stay tuned. We'll see you in a moment.